Okay, let's dive right in. We're going to talk about a procedure that's happening all the time in hospitals, but you almost never see it. It is incredibly precise, and for a patient who can't breathe, it's the absolute lifeline. We are talking about airway suctioning. I mean, just think about that for a second. A simple cough, it's something we all do without a second thought. But what if you couldn't? What if secretions like mucus or even blood started to build up and your body's most basic, most vital function, breathing, just stops? That moment of crisis is exactly where this all begins. You know, the body rarely fails silently. When an airway is in trouble, it sends out these really loud, really clear distress signals. And a nurse has to be able to spot these signs in an instant, because truly every single second counts. And you can see how this paints a picture of a crisis that's getting worse by the second. It can start with something you can actually hear, that awful gurgling sound from the blockage. Then you see it. The patient gets restless, they're physically fighting for air. And then the signs get even more terrifying. Cyanosis, where their skin literally starts to turn bluish from the lack of oxygen. And you look over at the monitor and see their O2 stats are just plummeting. These aren't just symptoms. These are alarm bells screaming that you're in a real medical emergency. So, when those alarms are blaring, what's the move? Well, you need a direct, hands-on intervention to clear that blockage, and you need it now. That intervention is airway suctioning. At its core, airway suctioning is kind of like a super specialized medical vacuum cleaner. It uses negative pressure to literally pull whatever is obstructing the airway right out. Now, that might sound simple, but the level of precision and skill that goes into this is just immense. It's the most direct way to get a patient breathing again, period. And if you look at these goals, you see right away this is about so much more than just cleaning out a tube. Obviously, the main goal is to keep that airway clear so oxygen can get through. But it also prevents something called aspiration. That's when those secretions slide down into the lungs, which is a fast track to serious infections like pneumonia. And for patients who are just too weak or too sick to cough, this procedure is literally doing the work their own body can't. To do this safely, a nurse can't just grab any old tool. They need a really specialized toolkit, and using it the right way takes a ton of technical knowledge. Every single choice, from the kind of system they use to the exact size of the catheter, is absolutely critical. So, there are two main ways to go about this. With open suctioning, you have to briefly disconnect the patient from their ventilator. As you can imagine, that opens the door to oxygen levels dropping and a much higher risk of infection. That is exactly why in the ICU, where patients are so incredibly fragile, the closed suctioning system is the way to go. It uses what's called an inline catheter, meaning the patient stays connected to the ventilator the whole time. It's just so much safer. But it's not just about the big system. It's about the tiny details of the tools themselves. And when we talk about the suction catheter, let me tell you, size is not a suggestion. It is a critical calculation that can be the difference between success and causing serious harm. Just look at this. These aren't just numbers on a chart. They're like critical codes that a nurse has to know by heart. A tiny newborn needs a delicate 5 or 6 French gauge catheter. An adult, more like a 12 or 14. And that golden rule at the bottom is everything. The catheter cannot be more than half the inner diameter of the patient's breathing tube. Why does that matter so much? Because if it's too big, you're literally blocking off the airway, cutting off their oxygen during the procedure, and you could cause real damage to the delicate lining of their trachea. And just like with the catheter size, the amount of force you use, that negative pressure, is a really delicate balancing act. You need enough power to clear out thick stuff, but too much force can actually injure the very tissue you're trying to save. You can see just how careful you have to be. A neonate can only handle 60 to 80 mmg of pressure. That is an incredibly gentle pull. An adult can handle up to 150. If you accidentally used adult-level pressure on an infant, well, you could cause serious trauma, bleeding, you name it. This isn't just about flicking a switch. It's about meticulously calibrating the machine for every single patient, every single time. Okay, so you've got the right equipment, it's all perfectly sized, perfectly calibrated. Now comes the moment of truth, actually doing it. And this whole thing happens inside an incredibly tight time frame that we call the 15-second window. Before anything even touches the patient, preparation is key. You explain what's about to happen, even if they aren't fully awake. But the most critical step on this list is that last one, pre-oxygenation. For up to a minute before starting, the nurse gives the patient 100% pure oxygen. This builds up a reserve in their lungs, creating a vital safety buffer for what's about to happen next. 15 seconds. That's it. That is the absolute maximum time a suction catheter can be down a patient's airway in a single go. Any longer than that, and you risk causing hypoxia, a dangerous nosedive in the body's oxygen levels. It is a genuine race against the clock. And the technique itself is so important. The nurse slides the catheter in without any suction on. That's to prevent hurting the tissue on the way down. Suction only gets applied on the way out, while gently twisting the catheter to grab secretions from all sides. Then, boom, the catheter's out, that 15-second clock stops, and the patient gets to rest to get more oxygen for up to a minute before you'd even think about another pass. And the whole thing is limited to maybe 2 or 3 passes total. It's just an incredible display of skill under pressure. And the job is not over when the catheter comes out. Not even close. Immediately, the nurse gives the patient more oxygen and then starts assessing. They listen to the breath sounds. Do they sound clear? They check the monitor. Are the oxygen levels coming back up? And they document every little detail about what they just removed, because that gives doctors vital clues about the patient's condition. The cycle is only complete once they've confirmed it actually worked. So, as we've seen, this is a procedure that saves lives, no question. But like any powerful medical intervention, it comes with some serious risks. Doing it right is a constant, delicate balancing act. This is so important to understand. Even though suctioning can pull a patient back from the brink, the nurse is actively navigating a minefield of potential problems with every single move. The stakes really couldn't be any higher. And here's what's at stake. We've already talked about hypoxia, that drop in oxygen, but the procedure can also stimulate something called the vagus nerve, which can cause the heart rate to suddenly and dangerously drop. That's bradycardia. It can cause trauma, bleeding, infection, and in patients with head injuries, it can even spike the pressure inside their skull. The nurse's expertise, their strict adherence to that 15-second rule, that precise control over pressure and size, that's the only thing standing between the patient and these very, very serious outcomes. So when you really break it down, you see this incredible amount of skill, knowledge, and precision that's packed into something that might just look like clearing out a tube. It really makes you think, doesn't it? What other simple things that happen in a hospital every day require the same level of hidden, life-saving expertise?